The second case that I want to present to you is a child who was 8 years of age, a male with bilateral true vocal fold lesions, initially diagnosed as a left vocal fold cyst with a right vocal fold contralateral lesion. The chief complaint was chronic hoarseness, and the child had had a trial therapy of anti-reflux medication. When you look at the pre- and post-treatment measures for this child, you will notice that the parents rated the pre-treatment voice 29 out of 92. The clinicians, however, rated the voice as a 61 out of 100 with a moderate to severe roughness, breathiness, and strain. Once again, the fundamental frequency, the noise to harmonics were within normal range, but at the higher end. And the intensity of the voice was a little bit louder than the first child that I presented to you, the intensity being in the 80s. The airflow was also at the higher end of normal, being at 198, and we did not have pressure data for this child. When you compare the pre-post, you'll notice that the parents did rate a change in the voice from 29 to 18, but the clinicians saw a dramatic change in the voice, or heard a dramatic change, I should say, in the voice, rating it from 61 to 8, with just a mild breathiness in the voice post-treatment. The other measures that you see there were fairly comparable. However, the airflow measure did decrease. Here are the laryngeal images and the voice samples for this individual. You'll notice in terms of the pre-therapy measure, there are some distinct lesions on the vocal folds. This child did undergo surgery, and 1 week post-op, you'll notice the changed condition of those vocal folds, and he was in therapy for 6 months. And you'll notice that following that period of time also, the image presents with a much better edge to that vocal fold, or to those vocal folds. The sound of the voice I will present now in terms of the pre-treatment, and it is as follows.
The blue spot is on the key again.
How hard did he hit him?
How hard did he hit him?
We were away a year ago.
We were away a year ago.
We eat eggs every Easter.
We eat eggs every Easter.
My mama makes lemon muffins.
My mama makes lemon muffins.
Peter will keep at the peak.
Peter will keep at the peak.
And next is this voice sample 6 months post-therapy.
The blue spot was on the key again. How hard did he hit him? We were away a year ago. We eat eggs every Easter. My mama makes lemon muffins. Peter will keep at the peak.
You'll notice that the child has a distinct difference in terms of that voice 6 months post-therapy, from not only the standpoint of the roughness, but also in terms of the resonance of the voice. And I will discuss that as I talk about the treatment. This child had 9 sessions. They were 30-minute sessions for 6 months, and he did very well in terms of compliance. A parent accompanied the child to each therapy session, and there was good participation within the session and excellent participation outside of the session at home. The treatment consisted of vocal hygiene to decrease the phonotrauma and increase hydration, and then 2 specific programs, the first being vocal function exercises, the second being resonance therapy. Vocal function exercises are a series of exercises that we use with voice patients that help to change, we think, the strength and balance of the laryngeal musculature. And for those exercises, the child is asked to sustain specific fundamental frequencies or pitch levels, pitch tones, and to sustain that tone with a very forward-focused resonance. We measure the duration of each tone, and we have the child practice those exercises at home with the parent, recording in seconds the length of time that they can sustain the tones. In this child's initial session, what we call the power exercises, which are a series of 5 notes, the child's mean duration was 14 seconds for those exercises, and by the final session, the mean duration was 25 seconds. In regards to resonant therapy, this particular treatment approach focuses on tone focus and assuring that the tone of the voice does not have roughness, which we refer to as back-focused resonance. We accomplish this by beginning with a very forward-focused buzzing tone produced at the level of the lips, and we proceed from this tone to various syllable structures, beginning with monosyllabic and progressing to combinations of syllables as long as 20 syllables in length, or sentences typical to conversational speech. This child began at the 1-syllable level in terms of producing a forward-focused resonance and progressed to a 20-syllable sentence level in terms of forward-focused resonance. And you'll recall as you listen to his post-treatment voice that you could hear that lilting of the voice as he produced the sentences from the Cape V exercise. That concludes my portion of this presentation. And next, you will hear some other cases presented by my colleague, Dr. Lisa Kelchner. Thank you.